Okay, having now looked at kind of an introductory discussion of VTE prophylaxis and then dedicating the last podcast to VTE prophylaxis in the setting of trauma, let's turn our attention now to several other specific groups, that of patients receiving neuraxial anesthesia, surgical oncology patients, and patients who are morbidly obese. As we will at times have patients who benefit from epidural catheters or spinal anesthesia, we should have some understanding of the risks associated with prophylactic and therapeutic anticoagulation in the setting of neuraxial anesthesia. As with everywhere else, there are blood vessels in the spinal epidural space, as well as in the spinal subdural and subarachnoid spaces. Injury can occur to all of these vessels, so the term spinal epidural hematoma is sometimes replaced with the more global term spinal hematoma. The most significant vessels are, however, the veins comprising the posterior internal vertebral venous plexus and the spinal epidural space, though. So the majority of these spinal bleeds do indeed arise from the epidural space. Injury to the plexus of veins can result in blood collecting in the epidural space, which, if severe enough, can act as a space-occupying lesion and cause damage to the spinal cord. Unlike the cranial epidural space, however, within which bleeding, when it occurs, is typically arterial, usually from the middle meningeal artery, spinal epidural bleeding is typically venous in nature from this plexus and will therefore usually stop fairly rapidly. When it doesn't, though, the resultant hematoma can lead to spinal cord damage with motor and sensory deficits if let go for very long due to the pressure which builds up. This can be, we're talking about it here in the setting of neuraxial anesthesia, but it can also occur as a result of spine trauma. It can spontaneously occur in patients who have coagulopathy or vascular malformations. And again, as we've emphasized so far initially, iatrogenically from lumbar punctures, spinals, epidural catheter placements, and other neuraxial procedures. When they occur, spinal hematomas typically present with severe back pain. Occasionally you'll see patients with radicular symptoms, but that's less common. It's just usually a focal and severe back pain, which can subsequently become associated with neurologic loss depending upon the location and the severity. The definitive diagnosis is typically made with MRI. This is frequently a neurosurgical emergency requiring rapid decompression with laminectomy. And the outcomes are worse if the diagnosis and the intervention is delayed, as you see here in this paper from the Regional Anesthesia Pain Medicine in 2018, where the yellow group here has highlighted where intervention was performed in under 8 hours, and an overall significantly better outcome than in this subset intervened upon after 24 hours, here highlighted in the purple. The overall incidence is low. However, one must keep in mind, overall incidence about 1 out of 8,000 with epidural procedures. The incidence is increased, though, in patients with coagulopathy, including those due to anticoagulants and antiplatelet medications, as well as in older patients and those with spinal abnormalities such as significant osteoarthritis. Epidurals, as compared to spinals, pose an increased risk. So you have an increased risk of epidural hematoma or spinal hematomas, to use a more global term, with epidural catheter placement, for example, as compared to a lumbar puncture or spinal anesthesia, likely related to the larger needles utilized and the placement of an indwelling catheter. Also, likely for multifactorial reasons, epidurals placed in obstetric patients have significantly lower incidence of epidural hematomas than do other surgical patients receiving neuraxial anesthesia. The risk in the OB population is more on the order of 1 out of 20,000. Regarding the level of risk in patients with receiving neuraxial anesthesia on anticoagulants. A good review of the literature and guidelines based upon this review are nicely summarized in a 2018 joint effort of the American Society of Regional Anesthesia and the European Society of Anesthesia. And you can see from this data, although the incidence of spinal hematomas are low, the presence of trauma, anticoagulants, and antiplatelets all increase the risk, particularly if they're combined. Also supported by this review of the literature is the intuitive observation that anticoagulation more proximate to the time of neuraxial anesthesia performance or catheter removal is associated with increasing bleeding risk. It also, frankly, makes a difference how smoothly the epidural or spinal procedure goes. If a bloody tap occurs, for example, the risk of subsequent bleeding complications is, as would make sense, elevated. Now, the guidelines authors recognize that this data in this publication, published in Regional Anesthesia Pain Medicine in 2018, they emphasize that the data is in many areas very limited and that the guidelines do not, as they put it, quote unquote, define standard of care. Having said that, they're really the best we have to go on. And so they are actually held by most anesthesia providers as such, regardless. So let's look at some of the guideline recommendations. In regards to prophylactic unfractionated heparin, as here in the yellow, the guidelines call for holding the sub-Q heparin in prophylactic dosing 4 to 6 hours before and 1 hour after neuraxial manipulation. Because of the longer half-life of low molecular weight heparin, for Lovenox, it's 12 hours before and 4 hours after. So unfractionated heparin 4 to 6 hours before, this is in prophylactic doses, and 1 hour after the neuraxial procedure. Low molecular weight heparin 12 hours before, 4 hours afterwards. The recommendation for therapeutic heparin is, interestingly, identical to that with prophylactic dosing. Again, 4 to 6 hours before, 1 hour after neuraxial administration. While for therapeutic Lovenox, it increases to 24 hours before, so it doubles, but remains 4 hours after. Other anticoagulants have different recommendations commensurate with their half-lives, as summarized here in the area highlighted in orange. For Coumadin, as seen here in the green, the INR just needs to be below 1.4 before a neuraxial procedure or catheter removal. Here in the purple, for Plavix and most other antiplatelet agents, one has to stop the medication for the duration of the platelet half-life at 7 to 10 days prior to neuraxial procedures, but they can be resumed fairly quickly after the catheter is removed. On the other hand, there is no limitation regarding aspirin and other NSAIDs. Okay, let's turn our attention now to looking at venous thromboembolism and prophylaxis thereof in the setting of oncology. Clinical VTE occurs in approximately 10% of all patients with cancer and is associated with increased mortality in these patients. Although many of these cases have additional risk factors such as surgery and limited mobility, just the neoplasm itself is in many instances a significant risk factor. And some cancers pose a greater risk than others. Amongst the neoplasms with which we deal with more frequently, gastric and pancreatic cancers are especially noteworthy in regards to having an increased risk of VTE. The type of neoplasm and other factors have been incorporated into a scoring system developed and validated by researchers at Duke and Rochester, looking specifically at oncology patients. The Corona scoring system is therefore of utility in selecting patients who may benefit from chemical prophylaxis, certainly during the inpatient setting where probably everybody needs it, but more so this is helpful in discerning those patients who may need it in the outpatient setting and during non-operative timeframes. Again, in relation to general surgery practice, this is probably most applicable to pancreatic or gastric cancer patients who are receiving preoperative neoadjuvant chemotherapy. So, for example, I have an obese patient with pancreatic cancer who's receiving several months of FOLFIRINOX or Gemabraxane. It may be a good idea to have them on prophylactic Lovenox during that neoadjuvant time frame, or at least be checking intermittent venous duplex studies along with clinical exams to look for evidence of DVT or other VTE related complications. We also need to keep in mind, however, the factors which increase the risk of bleeding with chemical prophylaxis against VTEs, as recognized by the improved data, and cancer is actually one of those. So as with trauma, in treating cancer patients, it's often a fine line between balancing the increased VTE risk with chemical and mechanical prophylaxis versus the increased bleeding risk that can be seen in some of these patients, particularly if the neoplasm has a concurrent association or coexistence with renal failure, hepatic failure, or thrombocytopenia, or perhaps the presence of active ulceration of some portion of the GI tract. Using data primarily extrapolated from several large series of medical inpatients with cancer, there is demonstrated benefit from chemical VTE prophylaxis. The NCCN and other authorities on oncology care take to heart, and therefore recommend chemical VTE prophylaxis basically in all cancer patients who are admitted in the absence of contraindications. Now, unlike trauma and bariatrics, the recommended dosing for prophylaxis is 40 milligrams of Lovenox daily. Again, though, adjustments should be made for over or underweight patients, as you can see summarized here from the NCCN website. Patients with renal failure can be covered with sub-Q heparin instead, although in cases of mild renal impairment, just adjusting the low molecular weight heparin dosing may be acceptable. Personally, if the creatinine clearance is less than 30, I'm probably going to use unfractionated heparin, and that's in line with the guidelines. But if you have a cancer patient who happens to be morbidly obese, again, adjusting the dosing as we talked about in relation to trauma patients, as we will talk about in relation to bariatric patients, may be reasonable. But like with general surgery patients, the standard dosing for somebody with kind of a standard weight range would be 40 milligrams daily instead of, like in trauma, 30 milligrams BID or 40 milligrams BID. So a little bit of difference there. Will that change in the future as more data emerges? Quite possibly. So all in patients with cancer are going to get, unless it's contraindicated, chemical prophylaxis as well as mechanical prophylaxis. What about when the patients go home, though? After discharge, if no surgery has been done, or if it's been a relatively minor surgery, such as, let's say, a mastectomy, a melanoma excision, or a thyroidectomy, for example, then most patients will not benefit from ongoing VTE prophylaxis unless either their mobility is impaired or they have an elevated corona score. So low-risk patient with a low-risk surgery or who's not had surgery yet, they probably just need the chemical prophylaxis while they're in the hospital. It can be stopped when they go home. However, if they're immobile or if they have a high corona score, and again, we see what the corona score is based upon here, the type of cancer, again, gastric and pancreatic give you some points. Also less points, but still points scored for lung, lymphoma, gynecologic cancers, and GU cancers, excluding prostate. Patients that have thrombocytosis, patients that have actually anemia, patients that have leukocytosis, and patients which are obese, all those scores go in, score greater than or equal to 3, even if they haven't had, a high-risk surgery or something. Those patients will likely benefit from ongoing chemical prophylaxis after discharge from the hospital. Okay, so that's basically some pretty good guidance for patients that have surgical oncologic issues that are taken care of with smaller surgeries or that are non-operative in nature, at least at that point. Essentially use the corona scoring to kind of guide us. What about patients, though, that have had sizable surgical oncologic procedures? In order to look at that, we really have to understand some of the orthopedic literature, as this kind of really led the way in regards to the data that we now have in regards to these patients. As the orthopedic specialty was really the first surgical specialty to generate significant data regarding potential benefit from more prolonged chemical VTE prophylaxis postoperatively. In the mid-1990s through early 2000s, there were no less than six randomized prospective orthopedic trials which demonstrated benefit in total joint patients receiving a full month of postoperative low molecular weight heparin as compared to those receiving 1 week. This prompted the study here at the bottom, the enoxaparin and Cancer 2 trial, which was performed by a group of Israeli and European investigators comparing 4 weeks versus 1 week regimens of 40 milligram daily of Lovenox postoperatively after abdominal and pelvic surgical oncologic procedures. Now, you'll recall, by means of background and what we looked at previously, the enoxaparin 1 trial published in 1997, which looked at low molecular weight heparin versus unfractionated heparin in the setting of abdominal cancer surgery, demonstrating slightly improved outcomes with low molecular weight heparin and increased ease of dosing. We talked about that as kind of one of the early trials. That article actually observed, interestingly, a fairly low incidence of late DVT, an observation which they commented on at the time near the end of the discussion session of that first study, contrasting it with the higher delayed DVT occurrences starting to be noted at that time in the orthopedic literature. As the orthopedic literature and data became irrefutable, though, regarding the benefit from longer duration of chemical VTE prophylaxis in selective patients, some of the same investigators from the enoxaparin 1 trial, again, I think important to note, funded by Aventis Pharmaceuticals, the producers of enoxaparin, which makes you a little bit concerned about maybe some bias, but nonetheless, these investigators constructed another double-blind, multi-center trial, this time with 332 patients. In order to meet the inclusion criteria, they had to have undergone abdominal or pelvic oncologic resections and be, again, greater than 40 years old. This study was conducted between 1998 and 2000, and it was across 37 European and Israeli medical centers. And they specifically compared 40 milligrams of Lovenox starting 10 to 14 hours preoperatively before these procedures and then continuing for 6 to 10 days, at which point then, so all the patients got that, at which point then they were randomized to either ongoing placebo or continuation of Lovenox at a dosing of 40 milligrams sub-Q daily to round out a total treatment duration of 25 to 31 days. So everybody got upfront Lovenox. It was then continued for a range of between 6 to 10 days, depending upon how long their hospitalization was. And then after that, this study group and the control group were given either retrospectively Lovenox 40 milligrams daily for a total of 25 to 31 days or placebo. The demographics of the two groups were well matched, as you can see here. And you can see the types of surgery which were looked at are, again, fairly well matched. The highest type of surgery of the GI tract, colon cancers, other GI tract cancers, comprising greater than 80% in both the placebo and in the study arm, along with about 10% urologic cases and a smattering of gyn-onc and other types of oncologic surgery cases. But for the most part, these are patients that we take care of, GI tract, major oncologic surgical resections. In addition to clinical follow-up, all patients underwent routine venography within 3 days of the injection discontinuation. So at the end of the study, all patients underwent routine venography as well as close clinical follow-up. And the results of the study did show a statistically significant lower incidence of VTE in the prolonged prophylaxis group at 4.8% versus 12% after 1 month, and at 5.5% versus 13.8% after a total of 3 months. So a statistically significant decreased incidence in VTE occurrence in patients receiving 1 month of Lovenox as compared to those just receiving it essentially during their hospitalization or during that 6 to 10 day immediate post-op period. I think it is important to note, though, not really much of a difference seen here between PE. Overall VTE rate, yes. Certainly distal DVT rate, yes. Proximal DVT rate, yes, but less so, but not interestingly with PE. It's also noteworthy to note that there was a slight incidence or increased incidence or a slight trend actually toward increased bleeding complications in the enoxaparin arm. But again, this did not reach statistical significance looking at the overall incidence of minor bleeding over the entire 3-month period, 4.7% in the enoxaparin arm versus 3.6% in the placebo arm, 1.2% versus 0.4% major bleeding risk, for a total bleeding risk difference of 7.1 versus 4.4% differences. So a trend that you see there with patients bleeding slightly more, not reaching statistically significant, however, with the prolonged low molecular weight heparin dosing. A similar study was performed using dalteparin, a different low molecular weight heparin, between 1997 and 2003 across 5 centers in Norway and Denmark. Again, the groups were appropriately similar. Again, the type of patients that we take care of, predominance of colorectal cancer, followed secondarily by gastric, biliary, and pancreatic cancers. And again, benefit was seen with a full month of low molecular weight heparin being associated with a VTE rate of 7.3% as compared to 16.3% over here in the yellow with just a week's administration. The number needed to treat in this study to prevent 1 case of a VTE was 12. A limitation, again, the study was funded by Pfizer, which does bother me quite a bit. We know that the pharmaceutical company funded studies do tend to be biased, at least to some degree. But again, I think we're seeing some congruency and consistency in the data, which I think argues the point reasonably strongly that there does appear to be benefit in patients with cancer who require a significant abdominal pelvic procedure from continuing to get chemical prophylaxis for a full month as compared to just for a week or for during their hospital stay only. Does this translate to an improvement in mortality? Neither of the studies were powered sufficiently to demonstrate an effect on mortality. However, other data, such as this data that was pulled from 211 ACS NSQIP hospital databases between 2006 and 2008, with a total of 44,656 patients, has demonstrated an increased survival benefit with chemical prophylaxis of a more prolonged nature, as well as observing that a third of postoperative VTEs after abdominal and pelvic surgical oncologic procedures occur after discharge. So does it make a difference in regards to mortality if you get a VTE or not? Yeah, it does seem to increase your risk of mortality, which kind of makes sense. And a third of these VTEs which occur after the time of discharge. So both of these observations from this large series of patients in the ACS NSQIP database provide additional argument for prolonged chemical VTE prophylaxis after these procedures. And I apologize, I failed to forward the slide here. Here's the slide showing the breakdown of the timing of the VTE, overall VTE, DVT, and PE occurrences, essentially consistently a third in each of the categories occurring post-discharge. Now, the preponderance of the data with VTE prophylaxis across the board, and that includes with surgical oncology patients, is with low molecular weight heparin, and that continues to remain the primary agent used. But there is some data out there supporting the use of fondoparinox or low-dose DOACs in certain settings, and this is recognized by the NCCN here, as you can see in their guidelines for post-discharge prophylaxis in surgical oncology patients. Again, the most commonly used one here is going to be enoxaparin or dalteparin in some instances where that's used, but also apixaban, rivaroxaban, and also in a separate page is fondoparinox can be utilized in some instances, although there's typically not a compelling reason to do so. So we typically, in most instances, will just use Lovenox or enoxaparin. So in summation, surgical oncology patients are treated like high-risk general surgery patients while hospitalized, with the significant difference that additional VTE chemical prophylaxis is indicated after discharge, going out until a total of 1 month postoperatively in patients who have undergone significant abdominal or pelvic surgical oncology procedures. Okay, let's conclude our discussion on VTE prophylaxis by looking at one other special surgical group, obese patients or bariatric patients. As recognized by the Padua prediction score, obese patients, likely for multifactorial reasons, have an increased risk of VTE. An autopsy series out of the Mayo Clinic, published in 2000, noted obesity to be an independent risk factor for fatal pulmonary embolus in a wide range of surgical patients, while a review of 10 postoperative bariatric surgery deaths at UCLA between 1994 and 2002 cited pulmonary embolus as the primary cause of death in 30%, or 3 out of the 10, as highlighted in the blue here, while 80%, or 8 out of the 10 patients, were found to have PE on autopsy. So in 3 of those, it was felt to be what killed them, but it was present in 8 out of 10. So these are just a couple studies highlighting the observation that's been echoed by other research as well, that venous thromboembolic risk is high in obese patients, and VTE prophylaxis is therefore of particular interest in patients undergoing bariatric procedures. Solid data in this area is, however, unfortunately lacking. Indeed, a 2022 Cochrane review concluded that not really much definitive whatsoever could be said on the topic. If you read through each of these, there's just not really a lot there in the way of strong data or strong recommendations. And congruent with this are the 2022 ASMBS guidelines, which says little more than low molecular weight heparin is probably better than unfractionated heparin. So we could probably just end this part of the discussion at this point with the recognition that a broad consensus in this area is not supported by the literature. In an effort to be somewhat more helpful, though, let's look at some of the individual publications generated by bariatrics teams. One of the studies which has most impacted our bariatric team's practice is a 2008 prospective trial validating a BMI stratified VTE prophylaxis protocol utilized at an Illinois community hospital. The protocol entails 5,000 units of unfractionated heparin actually being used here 2 hours preoperatively, along with SCDs being started preoperatively. Then postoperatively, starting 12 hours after surgery, the patients receive Lovenox, 40 milligrams BID if their BMI is less than 50, or 60 milligrams BID if their BMI is greater than or equal to 50. Also part of the protocol is ambulation no later than postoperative day 1 and preferably the night of surgery. They also endorse routine anti-10A testing and adjustments to maintain a range of 0.2 to 0.4 starting after the 3rd dose of Lovenox. And they also continued Lovenox after discharge for 10 days. And the investigators found that with this protocol, target anti-10A levels were achieved in 75% of patients within 36 hours. And this did translate to a low VTE rate with just one patient being noted on clinical follow-up to have a VTE. So one DVT on follow-up in these patients. And that was a patient that was found out to have hyperhomocystinemia, so really had an indication for potentially even therapeutic dosing. 5 patients had bleeding complications for a 2.2% postoperative bleeding rate, which is comparable to the 3.1% recognized during the same time frame in concurrently and previously published large series of bariatric surgery patients. Interestingly, 4 out of the 5 patients who had bleeding complications were in the 40 milligram BID group and just 1 in the 60 milligram BID. Of the patients who had bleeding complications, several were wound and incisional related bleeding. Several others were GI bleeding. 1 of the 5 patients required reoperation surrounding a traumatic drain removal on postoperative day 9. So while some bleeding complications were noted, the overall incidence was quite low. The majority of patients, I think it's noteworthy to mention, did not require significant titration based on the anti-10A levels, with 90% discharged on either the 40 or the 60 milligrams that they were initially discharged on. So really there was titration conducted. For all the hassle of anti-10A testing, it impacted only on 1 out of 10 patients. And the highest dose that was titrated to was 80. So not an enormous amount of benefit, one could argue, from the anti-10A testing. And this, again, is consistent with what we've seen in trauma before, and you may recognize this slide from the previous podcast, where in that, higher doses up to 0.5 milligrams per kilogram have been advocated for, but there's not typically much indication for going probably above 60 BID. So the 60 BID range seems to be kind of a sweet spot where most patients, unless they're massively obese, can probably just be maintained at. And I would argue that anti-10A testing is probably not necessarily all that beneficial, but it does seem that there is benefit from having kind of a BMI adjusted dosing, if you will, such as was performed in this study protocol, or in this group's protocol. And so that's the main point I want to make here, is that this single center study with a moderate number of patients validated a BMI stratified chemical prophylaxis approach. And although they did anti-10A testing, the results of this would argue that that likely is not that necessary. Now, of note, these patients did receive unfractionated heparin preoperatively and then low molecular weight heparin postoperatively, which is a little bit different than most of the data that we've looked at previously, which was, apples to apples, oranges to oranges, using either all low molecular weight heparin or all unfractionated heparin. This was done out of concern for potential increased risk of staple line bleeding that was thought to be more of an issue potentially with the longer half-life of the low molecular weight heparin. Other intraoperative hemorrhagic complications as well was a kind of a secondary concern, and there was some thought this might hypothetically be less or more easily controlled with unfractionated heparin when they developed this protocol. An observational cohort study of 31,499 patients in the prospectively maintained Michigan Bariatric Surgery Collaborative argues against the unfractionated heparin component of the Illinois protocol, or as it demonstrated in this Michigan study, the adjusted VTE risk to be lower in those patients receiving low molecular weight heparin for both pre-op and post-operative prophylaxis relative to those receiving unfractionated heparin at any point. And this was with equivalent bleeding complication rate. So this seems like a pretty reasonable protocol that, again, was validated in this bariatric experience, and it kind of echoes some of the trauma literature as well. So there's some harmony there between the two patient populations to argue for the BMI stratified approach, maybe capping off at 60 BID probably without the essentiality of anti-10A testing, but starting with Lovenox and not including this component of unfractionated heparin. And I believe you're on fairly solid footing making that recommendation based upon this data out of Michigan. So with that, we've kind of reached the end of what I think are really the pertinent aspects to discuss regarding VTE prophylaxis in our surgical patients. But certainly there are a number of unanswered questions and areas where the literature just is inadequate to have strong evidence-based opinions on things because the evidence just isn't there. You have to wonder, as you look, what will the future hold? Has kind of orthopedics, will they continue to lead the way? You're talking about aspirin for the prolonged prophylaxis in selected orthopedic patients and trauma. Is that something that will bear out for surgical oncology patients, perhaps, and perhaps give a little bit better ease of dosing and therefore better compliance? So will we be using more aspirin just as the orthopods are, as more data becomes available? Aspirin dosing, in the orthopedic, at least the New England Journal on trauma article, they use BID dosing just to be able to test it directly with BID Lovenox for compliance. But from a pharmacologic standpoint, does it just make more sense to do it once a day? And just in looking at how general surgery and surgery oncology patients tend to be, unless they're obese, dosed on a Q-day basis with a typical dose of 40 Q-day for most of our general surgery patients. But with trauma, 30 BID, 40 BID being recommended more. Is BID really better for general surgery too? And as more data comes out, will we see the shift to that like has been seen in trauma? So these are just a few of the unanswered questions, of which I think there are many. Hopefully this has been helpful. And in future podcasts, we'll move on to look at more on VTE diagnosis and management.